Hello and welcome to the Demonstrating Implementation Excellence stream of SNOMED CT Expo 2020. My name is Terence Sherd and I'm the Technical Operations Manager at SNOMED International, and I will be moderating today's session. If you have any questions for the presenter during the session, please use the Q&A box and we will answer them at the conclusion of the presentation. I'm now pleased to introduce Miguel Pedrera Jiménez from the Hospital Universitario 12 de Octubre, who is going to be presenting the use of SNOMED CT to identify and manage COVID-19 patient cohorts in a tertiary hospital. Miguel, it's over to you.
Thank you very much for the presentation. Hello everyone, I am Miguel Pedrera from the Hospital Universitario 12 de Octubre in Madrid region of Spain. I am the responsible of area of data in the IT department of the organization, and I am going to show you my presentation about the use of SNOMED CT to identify and manage COVID-19 patient cohort in a tertiary hospital. First, I want to say thank you to the organization, to SNOMED International, to make possible this event and also to invite us to be here. And of course, to say thank you to all the viewers of this presentation. So first, a brief introduction of the background of this work. As I said before, we are a tertiary public hospital in the Madrid Regional Health Services in Spain. We have a reference population of more than 400,000 people located in the south of Madrid City, and we have 20 primary care centers in the area. We are one of the bigger hospitals in the region and also in the country, with more than 1,000 beds and 6,000 professionals. We also have a research institute with 9 research areas, 8 laboratories, and more than 200 funding projects and more than 200 clinical trials every year. So in the COVID-19 scenario in our hospital and in the world, this situation has been the greatest global health challenge in recent years. In the Madrid region, there were more than 70,000 confirmed cases and more than 8,000 deaths as of June 20. According to official sources. During the pandemic, the average length of stay at the hospital increased by around 15%, and the burden of managing COVID-19 patients rose to become an overload that saturated the healthcare resources of the organization. In this scenario, EHRs have proved crucial in decision making, whether for clinical or for resources planning purposes, and also for data use that go beyond direct medical healthcare and are now as secondary use. So the challenge to be solved through EHR in the COVID scenario and in any condition are the identification and the labeling of the COVID-19 cohort, the prioritization of patients at higher risk, the complete follow-up of the COVID-19 patient, and the generation of data for multiple secondary purposes. For example, clinical research. And what do we need to provide adequate solutions? We need standardization. Where? Everywhere. We need standards everywhere. We need standard conceptual and information models. We need a standard data entry mechanism. We need a standard integration, standard data warehouses, and a standard ETL mechanism. We basically need to have all the necessary information at the right time and in the right way. We need a new EHR paradigm. We need to move of the classic paradigm, the document-based paradigm, to a new paradigm based on the data value. The document paradigm in system was designed is based on them, Data entry is designed based on clinical reports, for example, discharge report, consultation reports. Data are prisoners of reports. Outside of them, they lose context and the meaning. The narrative predominates over the structure and codified. And data are only understandable where it has been generated. Outside of this, their meaning is lost. But in the new paradigm, the data paradigm, data entry is designed to respond to real data needs, allowing continuity of care and also secondary use of it. Data do not belong to reports, but to the patient. The clinical report is only one of the possible outputs of the data. The structure and codified predominates over the narrative, and data are structured and encoded based on standards, allowing exchange without loss of meaning. That means semantic interoperability. And we, the Hospital Universitario 12 de Octubre, has formed a multidisciplinary team of high information, and with this team, nothing of this would be possible. This team is composed of health informaticians, clinical information officers, nursing information officers, laboratory information officers, pharmacy information officers, and hospital managers. And we also count with several partners in this work, and we want to say thank you to all of them. Especially, we want to say thank you to the Health Ministry of Spain, to the SNOMED CT National Reference, for the help in order to standardize new concepts of COVID-19 related in this terminology. So the methodology of this work is composed by 3 steps. The first one is identification of relevant concepts. The identification and management of the COVID-19 patient cohort in a hospital requires a basic set of data refreshed in real time. Firstly, it is necessary to classify patients according to if they suffer this disease or not. This case identification has been done implementing alerts in our systems and based on WHO specification, but adapting them to our needs and using SNOMED CT. 4 groups of patients have been identified. Patients with COVID-19 confirmed by a diagnostic test based on one ICD-10 code. Patients diagnosed with COVID-19 without diagnostic test, also based on another ICD-10 code, and 2 additional concepts: patient under investigation and patient discovered. But for patients who are into the 2 first groups, that means COVID-19 confirmed case and diagnosis, a series of more accurate classifications are needed in order to allow a better monitoring of their evolution. Thus, a concept has been assigned to patients who are at respiratory risk, as SNOMED CT concept. And also, this alert responds to a series of observable entities also codified in SNOMED CT. They are oxygen saturation, oxygen flow, respiratory rate, and blood pressure. And similarity, as SNOMED CT concept has been assigned to identify patients from nursing homes. So 6 clinical concepts have been standardized using SNOMED CT, and 3 of them correspond to the extended concepts from our national extension. In this table, you can see the complete list of concepts related to a patient level and clinical alerts implemented in our information system. You can see the description, the ICD-10 code based on the 2 first concepts, the SNOMED CT ID, and the SNOMED CT term. And you can see that 3 of them, COVID-19 confirmed case, COVID-19 diagnostic case, and COVID-19 discovered, are part of our national extension. Because in the time when this work was done, that means March and April, the international edition has not these concepts. And also, the respiratory risk alert use, as I said before, and in a transparent way to the professional, a series of clinical observations that have also been standardized in our organization using the SNOMED CT. The table shows this specification for the standard observation used to infer the risk alert of respiratory risk. You can see the concept oxygen saturation, the liver oxygen flow, respiratory rate, and systolic blood pressure. All of them are concepts of the international edition of the terminology, and all of them are part of the observable entity axis of the terminology. And with this identification and standardization, we can do the implementation in information system. The HR system of inpatient in our organization is from DXC. The patient level concepts are modeled within the domain of alerts, and the observable entities concepts are modeled as observations. This system allows the use of this standard information for individual healthcare, known as primary care, as primary use of the information. And in order to carry out our use of the data, known as secondary use, data from the healthcare information system is centralized in real time in an I2V2 repository. And through this repository and the Trinetics platform, our professional can query the repository data to manage the patient cohort and build research hypotheses. And the results obtained of this work, the first one, is the set of standardized concepts and data according to SNOMED CT that have been recorded in the healthcare information system and persisted in this system and also in the I2V2 repository. So in this table you can see the volume of data related to COVID-19 concepts of clinical and patient level alerts. You can see the name of the concept, the description of the concept, the number of patients who has each kind of alert, when was the first record of this kind of alert, and also when was the last record. As this work was being by the end of May, all the last record in this table is over 25 of May. But nowadays, all of these alerts are currently used in our organization. But we also have developed and implement tools that and functionality of our information system that use this standard data generated. For example, the COVID-19 dashboard is a functionality of our EHR system that allows to the professional a standard data entry and a complete patient follow-up. Because in this tool, the professional can see all the information generated around a single patient in a single view. And also, this is very important because this functionality allows to the standard data entry, and this data is used for the alert that I explained before, and also for secondary use in the I2V2 repository and other information systems. But also, we have implemented the clinical alerts in the EHR system of the organization, in the domain of alert. So it's very useful because when a professional goes to the EHR of a patient, the first thing that he sees are the alerts that the patient has. For example, in this case, you can see in the first picture a patient who has 3 alerts: COVID-19 confirmed case, COVID-19 respiratory risk, and patient from nursing home. This functionality was very useful in the hospital, and our professional really appreciate that. For example, like as a comment, when we implement that, a medical doctor of our organization write a tweet in Twitter, of course in Spanish, but here you can see the description in English, and she says how to monitor more than 500 admissions for acute respiratory disease every day with alert system. Thanks also to the IT specialists who have managed to install new alerts based on the patient's constants and their doctor assessment. For us, for our IT department, that is the most important thing, because we have to develop functionality and tools that have to be useful to the healthcare processes and to make a little bit easy the situation of our healthcare professionals in a very, very dramatic situation as the COVID-19 pandemic. So by last, the Trinetic use in COVID-19 in our hospital has two purposes. The first one is the clinical management. For example, resources use, protocols, treatment, and continuity of care. And also the research purposes. That means test hypothesis for research and clinical trial proposal. In this slide, you can see examples, real examples of real studies that carry out in our hospital in the COVID-19 pandemic. And as you can see in the picture, this tool allows to the professional, not informatic professional, just a healthcare health professional, to build a patient cohort using the standard concept and to extract this cohort in order to make over it analytics. For example, in this picture, you can see that a cohort of patients with COVID-19 confirmed by the diagnostic test or just diagnosis, and also use the observable entities that I explained before to extract the cohort of patients with COVID-19 in respiratory risk. And with this cohort and the platform, you can do analytics over the data. For example, you can see just 4 pictures of example of this analytics. The first one, for example, is a descriptive study of the cohort with the sex and age of patients. The second one is a treatment pathway. The third one is a comparative between 2 cohorts. And the last one is again a comparative between 2 cohorts, but with a outcome, for example, death or respiratory risk. I and my team, the IT department, we are not the experts to make this kind of analytics or make scientific and medical relevant question in the platform, but we are the responsible that all the data needed to make possible this analytics is recorded in the healthcare information system and sent in real time to the secondary use information systems. And finally, as conclusions, just to say that the identification and management of the COVID-19 patient cohort is critical to address this emergency situation. Clinical domain concept must be based on a specification from supported health and standardization organization, for example, SNOMED CT International. My hospital has chosen SNOMED CT as terminology standard since it constitutes a comprehensive and extensible clinical terminology. As you could see in the results of the 6 concepts identified for patient levels, 3 have required new concepts in the national extension of Spain. This set of concepts allow to manage COVID-19 patient cohort in the healthcare IT system, and professionals can label suspicious diagnosis and confirmed case of COVID-19, as well as prioritize patients with high risk of infection or poor prognosis through automatic alerts. Data also have been persisted in an I2V2 repository for secondary use purposes. And through specific and advanced tools such as Trinetic platform, complex queries have been implemented to extract cohorts, perform analysis, and develop research hypotheses. And we want to say thank you again to the project that have allowed to make this work possible, and also to say thank you to the SNOMED CT National Reference Center for Spain for the contribution to the generation of new concepts necessary for the representation of COVID-19 health data that in this moment doesn't exist in the international edition of the terminology. So that are the reference of the work, and that's all. Thank you very much.
Thank you, Miguel.
Okay.
That was a very good presentation on, I think, what is a very relevant subject at the moment. Thank you.
Thank you very much, and you for the two introductions.
That's fine, thank you. Can I just ask that all the attendees just give us a couple of moments while we switch over from our pre-recorded content so Miguel can address the questions that you have been submitting live during the presentation. I would also like to remind attendees that this session will be available on the event platform for the next 3 months if you wish to watch. Thanks very much there. I think it's really good to see how not only your team managed to get the sort of data together, but how it was used in an EHR, and I think that's really interesting. Just to ask people, if you've got any questions for Miguel, please enter them into the Q&A box, and we can answer them during the session. So first question for you, Miguel, in your own experience, what are the main challenges in the organization that wants to implement this sort of functionality is going to face? Miguel, are you muted? Miguel, I don't know what's happened. It's actually not coming through. No, apologies, we're having some technical issues with the live Q&A session. Just give us a couple of minutes while we try and sort them out.
Hello, sorry, can you hear me now?
Yes, I can hear you, Miguel.
Sorry, we had a problem with my computer. Sorry, very quickly, I respond the question. I think that in the IT...
Hang on a second, Miguel. We're not actually broadcasting at the moment. We're just checking. There's a bit of a delay, so we're just checking if it's actually coming through.
Very quickly, sorry.
No worries. Okay, shall we go ahead and answer the questions anyway, Miguel? And if
yeah, sorry.
we can start broadcasting, then we can get it started. if I just repeat the question, in your own experience, what are the main challenges any organization that wants to implement this type of functionality is going to face?
Yes, sorry for the problem. I think that in the information system side, not in the clinical side, the main problem is to adapt the information systems to this new paradigm that I comment in my presentation. You need information system can respond to this new challenge in COVID pandemic and in other scenarios, and that only is it's only possible if information systems are based in good practice of modeling with dual modeling, incorporating terminological standards like SNOMED CT. And in our case, this is not a real problem now because we can adapt our EHR system, and we are collaborating with the company who provide it. So in our case, it is a challenge solved now. And the other typical problem in our organization who can to make this kind of project is the build a multidisciplinary team composed by informatics and medical experts, and in our case, we also get now that.